Brief presentation on superior sulcus tumors, more commonly known as Pancoast tumors. By definition, a Pancoast tumor involves a non-small cell lung cancer located at the apex of one of the lungs. These tumors represent only 5% of all lung cancers, and by definition, they involve the chest wall. Due to the chest wall invasion, patients present with chest or arm pain. Paresthesias involving the medial aspect of the arm are also common. Some patients experience motor dysfunction in the ulnar nerve distribution resulting from involvement of the brachial plexus. Others develop a Horner's syndrome characterized by ptosis, meiosis, and anhidrosis. More advanced Pancoast tumors may involve the vertebral column, subclavian vessels, or brachial plexus. The most common symptoms are neurological in nature. Patients complain of chest, shoulder, or arm pain. Paresthesias of the upper arm or the ulnar aspect of the lower arm are frequently found. With more extensive involvement of the brachial plexus, some patients experience atrophy of the intrinsic hand muscles, or they lose the triceps reflex. Involvement of the sympathetic chain may cause the Horner's syndrome. Less commonly, patients complain of cough, shortness of breath, or hemoptysis, which are symptoms that are typical of more centrally located tumors. As with any type of cancer, staging is an important early component of the management of these tumors. Virtually all tumors are evaluated with PET imaging to assess for metastases to the mediastinal lymph nodes or elsewhere throughout the body. Brain MRIs are performed even in the absence of specific neurological symptoms. This is done due to the extent of the surgical resection required for a Pancoast resection. MRIs of the thoracic inlet are also performed to assess for involvement of the brachial plexus or subclavian vessels. Several studies have shown that MRIs are more sensitive than CT imaging for determination of vascular or nerve involvement. A tissue diagnosis is usually obtained with CT-guided needle biopsies. Transbronchial biopsies are less effective because of the peripheral nature of Pancoast tumors. Tissue sampling of the mediastinal lymph nodes should also be performed even in the absence of radiographic evidence of involvement. This can be performed either by EBUS or mediastinoscopy. When selecting patients for this operation, it is important to focus on three aspects. First, the tumor must be technically resectable, and this is determined by evaluating the extent of local tumor invasion and by assessing for distant metastases. Two other important components are determining that the patient has an adequate cardiac and pulmonary reserve to tolerate the operation. The need for a cardiac stress test can be determined by assessing the patient's exercise tolerance and by determining if the patient has specific cardiac risk factors such as the presence of diabetes, renal insufficiency, congestive heart failure, a prior MI, or angina, as recommended by the American Heart Association and the American College of Cardiology. The patient must also have an adequate pulmonary reserve to tolerate the planned lung resection. The postoperative predicted FEV1 and DLCO should each exceed 40% of the predicted values. It is important to remember that the actual pulmonary function nadir in the immediate postoperative period is less than the calculated values due to pain. This nadir is even lower among patients undergoing Pancoast resections due to the extensive chest wall resection. To have a better understanding of our rationale for the current management of Pancoast tumors, it is important to look back into history. Edwin Hare described a patient in 1838 who presented with an apical chest mass, shoulder pain, and muscle atrophy in the ulnar distribution, which we now recognize as being consistent with the Pancoast syndrome. Later, Henry Pancoast, who is a radiologist, described a series of 7 patients with similar symptoms and apical chest masses. These lung opacities were initially believed to be infectious in nature or embryonic rests. The malignant nature of these tumors was not recognized until 1923. Since we currently have no randomized studies indicating the optimal treatment of Pancoast tumors, it is helpful to assess the outcomes of patients treated during 3 different eras. The first era was between 1930 and 1950, where Pancoast tumors were considered inoperable. During this era, patients were treated primarily with radiation. Patients received between 45 and 70 gray of radiation. It was recognized that a dose in excess of 50 gray was associated with a greater morbidity and mortality rate, but at the same time, this dose was more efficacious. With this treatment, the 5-year survival rate was approximately 5 to 10%. During the second treatment era, ranging from the 1950s to the 1980s, surgery and radiation became the preferred treatment plan. Initially, patients were treated with surgery first, followed by radiation, but in the 1960s, Shaw and Paulson recognized that patients who were initially deemed to be unresectable became resectable following treatment with radiation. In the 1980s, Shaw again demonstrated that preoperatively treating patients with 30 gray of radiation followed by surgery led to superior outcomes. These patients had a 5-year survival rate of approximately 30%. For this reason, neoadjuvant radiation followed by surgery became the preferred treatment plan, but during this era, patients with significant spine, vascular, or nerve involvement were excluded from the treatment plan. Between the 1980s and the late 1990s, neoadjuvant radiation followed by surgery remained the preferred treatment for patients with Pancoast tumors. However, during this time period, there was an extension of patients who were eligible for this treatment. Patients with spine or subclavian vessel involvement were now included, and despite their inclusion, the 5-year survival rates remained approximately 30%. Early in this period, patients were treated with between 40 to 60 gray of radiation, but this dose was later reduced to 30 gray in an effort to reduce perioperative morbidity and mortality rates. The current treatment plan that includes neoadjuvant radiation and chemotherapy followed by surgery was initiated in the past decade. The final results of one of these studies was published in 2007. In this study, patients were treated with 3 cycles of cisplatin and etoposide, or paclitaxel, followed by concurrent chemotherapy and 45 gray of radiation. After the completion of this treatment, patients underwent surgical resection. With this treatment package, the 5-year survival rate was 44%, and 54% of patients were found to have a complete pathological response with no viable tumor identified in the resected specimen. When neoadjuvant therapies become very successful and show high complete pathological response rates, the necessity of surgery sometimes comes into question. I believe the role of surgery in Pancoast tumors will remain, based on the uncertainty of identifying patients who had a complete response. In a retrospective study of 52 patients with various stages of disease, 13 of 22 patients who underwent surgery had a complete pathological response. However, our current imaging is not capable of determining which patients are complete pathological responders. In the study previously noted, preoperative imaging, shown in the column on the left, predicted a partial response in a total of 8 patients and stable disease in 13 patients. A complete pathological response was not predicted in any patient. As shown here, 6 of the 8 patients predicted to have a partial response by imaging actually had a complete pathological. 9 of the 13 patients with stable disease predicted by imaging had either a complete or a partial response. 1 patient, indicated by the white box, actually had disease progression. It is clear that imaging does not predict which patients are complete pathological responders, and therefore surgery remains an important component of their treatment. When approaching a patient surgically, it is important to divide the thoracic inlet into 3 separate components that are defined by the anterior and middle scalene muscles. The anterior component is located anterior to the anterior scalene, as shown here in the illustration from Frank Netter. This component contains the platysma and sternocleidomastoid muscles, the jugular and subclavian veins, and the inferior belly of the omohyoid muscle. It also contains the scalene fat pad. The The middle compartment is located between the anterior surface of the anterior scalene and the posterior aspect of the middle scalene. This compartment contains the anterior and middle scalene muscles, the phrenic nerve, subclavian artery, and brachial plexus. Tumors invading the anterior or middle compartments of the thoracic inlet are often approached through an anterior transcervical transthoracic or D'Arteville approach. This approach provides exposure to the C7 through T3 vertebral bodies. It also provides optimal exposure to the brachial plexus and subclavian vessels. Exposure for this operation is established by making an incision along the anterior aspect of the sternocleidomastoid muscle down onto the manubrium. The incision is then turned lateral along the top of the third rib. The medial one-third of the clavicle is resected as shown here in this illustration from operative techniques in thoracic and cardiovascular surgery. This facilitates en bloc excision of the subclavian vessels if necessary. Typically, the subclavian artery is reconstructed if it is involved, but reconstruction of the subclavian vein is not needed. The posterior compartment is located posterior to the middle scalene muscle. This compartment contains the nerve roots of the brachial plexus, the long thoracic nerve, sympathetic chain, and vertebral bodies. Tumors invading the posterior compartment, as shown here, are typically approached posteriorly, and this represents the majority of patients with Pancoast tumors. For this approach, a posterior lateral thoracotomy is performed in the fourth or fifth interspace, and the incision is extended superiorly to the spinous process of C7. The trapezius and rhomboid muscles are divided, which provides exposure to the transverse processes of the vertebra where they articulate with the ribs. The involved ribs can then be disarticulated from the transverse processes to be resected en bloc with the tumor. Occasionally, the transverse process needs to be transected and included with the tumor specimen to assure a negative margin. For an excellent description of both the posterior and anterior surgical approaches, please see the referenced issue of the operative techniques in thoracic and cardiovascular surgery. There are several areas of controversy regarding patients who may be candidates for a complete surgical resection. The presence of N2 disease is one of them. We know that positive N2 disease is an important negative prognostic factor in patients with non-small cell lung cancer, including Pancoast tumors. For this reason, many treatment protocols involving surgical resection of these tumors have excluded patients with N2 disease. However, some authors have shown no difference in outcome among patients with N2 disease compared to patients without N2 involvement. Not surprisingly, this question has not been evaluated in a prospective randomized study. In my opinion, however, the balance of data suggests that N2 disease is a strong negative predictor for survival and should be used as an exclusion criteria when considering surgery in a patient with a Pancoast tumor. A similar issue involves the presence of positive supraclavicular lymph nodes. Under most circumstances, supraclavicular lymph nodes are considered N3 disease for patients with lung cancer. However, there is limited evidence that with upper chest wall invasion, patients with positive supraclavicular nodes behave much more like N1 disease compared to N2 or N3 disease, and that long-term survival can be achieved following surgical resection. Therefore, involvement of supraclavicular lymph nodes does not necessarily preclude resection. A third issue regards involvement of the brachial plexus. Resection of the T1 nerve root typically leads to some numbness and weakness of the intrinsic hand muscles, which is fairly well tolerated. However, resection of the C8 nerve root causes significant hand dysfunction. Nerve involvement can be assessed preoperatively with an MRI and physical exam. Pain along the ulnar aspect of the forearm is consistent with T1 involvement. Pain extending to the hand or atrophy of the muscles innervated by the ulnar nerve is consistent with C8 involvement. If surgical resection is performed, the patient should be well informed about the potential lifelong neurological dysfunction. Historically, vertebral body involvement was associated with a high incidence of incomplete resection leading to local recurrence and poor long-term survival. More recently, acceptable survival has been demonstrated using a combined surgical approach that involves thoracic surgeons and neurosurgeons. Not surprisingly, survival is significantly greater among patients achieving an R0 resection. Vertebral body involvement should not definitively be used to exclude patients from surgical resection. In summary, Pancoast tumors represent a small minority of patients with non-small cell lung cancer. Historically, resection of these tumors was associated with high rates of incomplete resection and therefore local recurrence. However, in the current era, where patients are treated with neoadjuvant chemotherapy and radiation followed by surgery, acceptable 5-year survival rates can be achieved.